Hey, internship folks. So this is my sample presentation for you all uh, for your discussion leading. I'm using Zoom to record a video over PowerPoint. Y'all can just talk or do a narrated PowerPoint, whatever works for you. So I'm going to talk about psychological factors in bariatric surgery, which is what the article I posted is about. So this is something I did a lot of when I was on my placement, my 4th year of grad school. So I worked half-time, like 20 hours a week at a hospital. And during that time, for a full year, I did 131 pre-surgical evaluations for people considering undergoing bariatric surgery, which is what they used to call stomach stapling. And now they call Roux-en-Y gastric bypass, gastric banding, and gastric sleeve. So this is actually a presentation I gave potential patients. This will be a little bit different than what you all will do, but just to give you an idea. So this is just my overview. So people would often say, like, what does psychology have to do with my surgery? It's a very significant surgery. When you undergo these surgeries, it can be really difficult to adapt. You have to really change your lifestyle. You have to change your diet. If you eat certain things, you can get really, really sick, something called dumping syndrome. And you need to make sure you have all the resources you need to succeed post-surgery. Eating and emotions are linked, and it can be difficult to separate even post-surgery. A lot of my patients would try to say, oh, well, I'm not going to have that problem post-surgery because I won't want to eat. That's not how it works. You're still going to want to eat, even if you have the smaller stomach that it creates. So there are a lot of positives after people have surgery. Their mood tends to improve. Their self-esteem tends to improve. They're really motivated to change their behavior. But they can have a sense of deprivation in eating. You need to come up with different coping strategies. If food has been how you've coped, it doesn't work anymore. Some will have body image issues. Some will have fear of weight regain, and that's a realistic fear because a lot of people do regain the weight. The stomach's very elastic, so even though they make it the size of your fist with this surgery, it can stretch back out. And then not meeting weight loss goals. So in terms of research findings, successful surgical outcomes, people have the most weight loss and also the best improved quality of life is associated with not grazing. So grazing is where you just eat a little bit at a time throughout the day, the whole day. And people who have bariatric surgery can still do that and consume a lot of calories that way. You will have a strong social support network. People who are highly self-motivated and have self-efficacy, believe that they can do this. Patients with pre-surgical disordered eating will show short-term improvement, but then about 2 years later, they'll revert to their disordered eating habits, whether that's binging and purging or not eating. And it can be related to weight regain. If you are binge eating pre-surgery, it may be associated with vomiting post-surgery, which is not good. And I think that's related to failed attempts to binge eat. So when people came in, when I was on my placement, they would do a 2-hour appointment. They do 1 hour of an interview, and then they'd have an hour of questionnaires that they'd fill out. And the interviewer was either a psychologist, my supervisor, or one of the psychology, they called us externs. And that was me and my friend Nina the year I did it. So we asked people why they were interested in getting the surgery. We asked them to explain the surgery to us, the risks, what life changes they'll have to do to make sure they understood. We talked about their weight and diet history. A lot of these people have tried every diet but in the book. They'd list 10, 12 diets they had tried. Substance use history, we really want to look at that because sometimes what happens is what's called switching addictions. So someone who's never had a drug or alcohol problem, because they can no longer eat to cope, will start to use substances. Medical surgical history, how they've reacted to things like anesthesia. Psychiatric history, we especially want to know if they're on psychiatric meds and make sure they're working with their psychiatrist to manage that afterwards. Social history, so sort of what is their past like, and that kind of dovetails with what's their current living situation and who's there to support them. So the questionnaires gave us more information about them. We also used them for some research we were doing, which they did consent to. And as we explained to them, certain people feel more comfortable disclosing information on pieces of paper rather than face to face. So we asked about eating habits, mood, anxiety, stress, and then there was a like, do you understand the surgery? So these were the three possible results that people could get from their eval. No contraindications. This was the most common. I would say probably 70 to 80% of the people I saw got this. Patients seemed psychologically ready to make the necessary life changes to succeed with their surgery. Sometimes we would recommend therapy, but not require it. You don't have to undergo therapy, but we think it'd be a good idea to help them prepare. We used this designation because if we said someone had to do therapy, it actually affected what the surgeon can do. So if we required therapy, it was again rare, and it was some psychological factor might get in the way of post-surgical success. So they had to participate in therapy prior to surgery. Reason therapy might be required. Uncontrolled psychological disorders. The most common that we saw were disordered eating habits, especially binge eating or emotional eating. Substance abuse, cognitive difficulties. So sometimes people just didn't have the mental facility to understand things going on. And so then therapy would just focus on education till they got to understand what they needed. There might be other disorders like depression, bipolar disorder, anxiety disorder, and sometimes people just didn't have coping skills. So one of the red flags for me when I was doing these interviews was I asked them, what do you do when you're stressed out? And they said, I eat. And I would say, okay, so what if you couldn't eat? And they would be like deer in headlights. I don't know. So we talk about disordered eating habits that we saw. So binge eating a large amount of food in a short amount of time, with a sense of loss of control, especially doing so frequently. Purging after eating, vomiting, laxatives, things along those lines. Emotional eating, often emotions like sadness, nervousness, anger, fear, boredom. We all might be experiencing that right now as we are, doing social distancing, stressed out about COVID. And then eating in response to stress. And this is that question I just referenced. Substance abuse. So this is something I typically wouldn't help them with. We would refer them to someone who specialized in this. But these things would interfere with your ability to follow medical orders, and it could affect your ability to heal. Alcohol abuse in particular, you're having empty calories, and you're not supposed to have anything carbonated after surgery because it can help stretch back out your stomach. So again, cognitive difficulties, as I mentioned, we basically help people figure out how to make the changes they need to make. So yeah, again, checking with, are they going to be able to comply with what they need to do? So people who were required to go through therapy would ask, why do I have to go through therapy? And it's really to ensure post-surgical success, to make sure that they could carry out the surgeon's orders. So our philosophy that we always explain to patients was, why go through all this time, all this money, all these appointments, undergo major surgery, only to undo everything the surgery did because you couldn't make or stick with the lifestyle changes. So everything we did was in their best interest, but they didn't always see it that way. So these are common arguments I heard against doing therapy. I won't be hungry post-surgery, so emotional eating won't be a problem. Hunger and eating in response to emotions are two different things. Will what is causing you to eat now still be a problem after surgery? Probably. I can make these lifestyle changes when the time is right. I just haven't yet. So we would have them practice eating the way they were going to have to eat after surgery, because practice helps. The best predictor of future behavior is past behavior. This is another one that I would get. You're doing this just to get money. I got paid like 12 grand a year to do this, and it didn't matter how many clients I saw. So clearly no. So what does therapy entail? So we really focused in on the specific issues for the therapy referral. We weren't going to go into like your childhood or your mom. Usually it was 10 sessions or less. I would say most common was like 4 or 5. And we did individual therapy in our offices, and we also ran a group at night for people who are both pre and post surgery. They could be referred to another agency if they wanted. They just have to have a letter, and we just said, we have a relationship with them already. Here, as we mentioned, post-surgical problems are not uncommon. So sometimes they would regain weight or they would just sort of plateau, often due to emotional eating. The lifestyle changes were really hard. So a lot of people had a hard time coping with them. You have to eat these very small meals and exercise a lot. And it's just difficult to fit into a sort of normal day-to-day life. So people have difficulty dealing with their changing appearance, not only the weight loss, but oftentimes they lose weight so fast they end up with like skin rolls, and that can be difficult to deal with. The transferred addiction I talked about before, or maybe you have something else come up, right? So non-related stressor, a global pandemic. If you'd like assistance for any of those things, we were always there for them. So again, talking to them about individual therapy. We used cognitive behavioral therapy. We did a lot of food monitoring and helped people change the patterns that were maladaptive, helping people come up with other coping skills they could do, and just really awareness of what you're eating. A lot of times we eat so quickly and while we're doing other things that we don't realize, oh, I just ate my entire Chipotle burrito and I only meant to eat half. So again, we would often refer people with substance abuse issues. And again, trying to do it before surgery so it doesn't interfere. Depression, we would usually do CBT, and we might refer for medication. Bipolar disorder, again, some therapy, probably some medication. Anxiety, we would do relaxation techniques, coping mechanisms. Obviously, suicidality or self-harm, we would hospitalize right away. I don't recall any of my folks needing that immediate hospitalization. We also, if they had PTSD and we thought that was going to interfere, luckily, like right down the hall from us, there was a Center for the Treatment and Study of Traumatic Stress. So we would just refer them there. The group therapy, it was to address disordered eating. There were other groups available, coping with overwhelming emotions, substance abuse. There was a anger management group. So we called our group the Inch group. We tried to come up with something clever. I don't know how clever it was. Incorporate new solutions and change old eating habits. Yeah, it's a stretch. I know. So again, focusing on how and why we eat, not on what we're eating, identifying thoughts, behaviors, and emotions that interfere with healthy eating habits, help them develop those eating habits, awareness of food intake, and then finding those alternate activities and learning to apply problem solving instead of eating when stressed. So we would have brainstorming sessions in group. What can you do if you feel like eating? And people would often say something to keep my hands busy, something along those lines, knitting, playing solitaire, something like that. It was a 10-week group with 1 hour, 15-minute sessions each week. I was co-led by 2 doctoral students in psychology. I think the smallest group I had was 2. The largest group was like 8 or 10. So it varied. And then there was work outside to keep momentum going. In classic CBT, we call this homework. We find that if we reframed it like work to keep your momentum going, people were more willing to engage. And this is based on therapy developed by Dr. Christopher Fairburn in Oxford, England. So there's 4 stages. First, you monitor your eating, then you establish regular eating, then you are aware of the patterns and thoughts about eating that are problematic, and then problem solving, the big thing that we spend a lot of time on. We also incorporated something Fairburn doesn't do, which is mindful eating. So being aware of what you're eating. There's an exercise you can do with a raisin. So if you have any raisins in your house, you could try this, where you take a raisin and you feel it, you smell it, you look at it, you crinkle it next to you, and then you taste it very slowly. And it's obviously that's an extreme version of what we want people to do, but it gives the example of, what you could do. This is old information, obviously. We had referral information for them, and that's it. So I hope that's helpful to you all as an example of what you might do. And this is a longer PowerPoint than I would expect from you all, just because it's one I already had pre-existing. And I will also put up some other examples of things. I've already put up my article. I'll put up some example discussion questions, things along those lines. Okay.